Welcome to the Digital Health and Innovation Podcast, a publication of the Southern Medical Association. This podcast will educate and inform listeners on the various systems and methods that use information, data, and communication technologies to help resolve problems, reduce inefficiencies and costs, improve access, increase quality, and help make the practice of medicine more personalized and precise.
All right, this is our first out of 3 series on Kaizen, and we are very glad to have Dr. Migita again on our call, and we welcome him again, returning to Southern Medical Association for another series of podcasts. Dr. Migita, thank you for coming on the line, talking about this topic of Kaizen.
It's a pleasure to be here. Thank you.
Thank you. So I have a list of questions about Kaizen, and I was going to review some of these with you. This might be a little bit of longer podcast compared to the one we had about lean and total production system in healthcare, but we just want to make sure that we cover all these questions and all the requests that came for us and basically take advantage of your presence. Without further ado, my first question is, why lean and why now?
That's a great question, and some people may think it's bad form to answer a question with another question, but I think that's what I would do. I would say, well, first of all, how you define lean. I think we talked about that in the first podcast, but secondly, I'd say, well, whose decision is it to implement lean? And I ask this question because the point is that lean or TPS, total production system, it simply won't happen in any institution, in any industry, if the top leadership doesn't say that it's important to the institution. The why and the now has to come from the very highest levels, the CEO, the chief medical officer, the chief nursing officer. They need to believe it, because if they don't and don't instruct their staff that this is what their institution needs, it simply won't happen.
So some of the questions that people may ask are like, patients are not cars. How does the manufacturing method apply to healthcare?
Patients are not cars. That's absolutely true. And virtually everyone that works in the healthcare industry, if they're not familiar with TPS, if they haven't bought in already, are going to say this. We're not studying how to make cars. We're not studying how to make airplanes, like we talked about with the Boeing example from the last podcast. At the end of the day, when you're manufacturing a complex piece of machinery, like a car or an airplane, that product cannot talk to you. It cannot say that this wiring is incorrect, or this airbag will not deploy, or this shock absorber has been installed incorrectly. Cars cannot speak to you, neither can airplanes. So the errors are hidden. The errors have to be brought out in product testing. And heaven forbid the product fails in the hands of a customer. So my point is that what makes people think that the application of TPS is more difficult in healthcare? Our patients can tell us when there's an error with their body and how it's functioning. They can tell us. They can feel pain. We can understand when a patient needs to go to the operating room, when they need antibiotics. We get direct feedback. So for this reason, I would argue that implementing lean is actually much simpler in the healthcare setting. It seems counterintuitive, but I truly believe that is true.
So what if somebody says, listen, we're not Virginia Mason, we're not Seattle Children. We are larger, smaller, we're government run, we're private, we're nonprofit organization. How do we go about this?
I guess, again, I'd ask another question. Does that matter? From the patient's perspective, if we believe the customer, our patients, is the most important piece of this chain, does it matter if you're big? Does it matter if you're faith-based? Does it matter if you're not Seattle Children's or Virginia Mason? Our patients need, deserve, and demand care across the outpatient setting, the inpatient setting. This is an excuse. This is an excuse not to improve. I don't mean to be flip about it, but that really is the truth. If you say you cannot implement improvement science in your institution, you're not thinking in terms of your customer. It's the courage that I spoke about in the last podcast, the courage to change, the courage to learn and look from outside of the traditional healthcare educational circles, to borrow proven concepts from industry. It's a foreign group of teachings for clinicians and hospital administrators, but I truly believe you must think about your patient and what they need. Because at the end of the day, good patient care is profitable. And profitability, of course, is important for any institution. Harm and poor outcomes, it's the ultimate waste on so many levels.
So, as you know, Toyota had some quality issues in the past and recalls. So some may ask this question, okay, so does Kaizen really work? Kaizen doesn't work.
True. I mean, every product has defects. Some products have multiple defects. And anytime you have human beings touching a product, anytime you have human beings making a decision, there's a fallibility there that occurs, whether it's healthcare or building any widget or car or airplane or what have you. What Kaizen is about finding the mistakes. Kaizen is about continuously improving and eliminating the root causes of those mistakes, which can have very serious human consequences. The world is in a natural state of having more errors and more defects than it is a place where there are fewer defects. It's the fallibility of the universe. There are defects everywhere. So to say that concentrating on eliminating those defects is somehow futile or should somehow be rejected because other manufacturers have had quality issues is really missing the point of improvement in the first place.
Okay, so some may say, we try TQM, we try the Six Sigma, quality circles, all the other methods years ago, and it didn't work. So why should we do this again?
Well, if there's no need, then there's no point. There's no point. If you live in a perfect system, where you never make a mistake, where everything is as efficient as possible, when all the patients and families are satisfied with their care, where you're meeting every quality indicator, every efficiency indicator, every financial indicator, then there is absolutely no point in improving. There's no point in looking for new methods and new mindsets to improve your organization. So every organization has need. Every organization has need.
How would you respond to this? Our last improvement effort failed, so that means Kaizen clearly doesn't work.
Well, there's levels of Kaizens. There's Kaizen is a skill. Kaizen is a skill to be learned. Kaizen is a mindset that the way you do things right now in your current environment is not the right way. That takes a tremendous amount of curiosity and courage to accept. But the frontline staff needs to see their leaders accepting that first. So if someone would tell me their last improvement effort fails, I would say, well, what is the root cause of that failure? Just like you would diagnose any problem. You'd ask your 5 whys, you perhaps would do an Ishikawa diagram, you'd find the root cause, and you design a countermeasure to make sure that that problem never happened again. So if the quote improvement efforts failed, what was the root cause? Did you not have the proper mindset? Did you not have the proper training before you tried to implement? Did you not have the commitment of senior leadership? What was missing? So I would ask those groups to do root cause analysis of the failure itself.
So another argument would be healthcare volume are not predictable like car orders. Can you really know your true demand?
Can you know your true demand? Hospitals fluctuate from being very busy to not being very busy, and there's downtime. That downtime can be used for a number of different things. It can be used to do Kaizen. But at the end of the day, if you're a hospital system, you need to try to make that demand, that downtime, productive. You should be asking a different question. You should be asking the question of how can you make that downtime more predictable so the institution can survive. So knowing your demand is not as important as shaping that demand and creating a system where increased volumes can be managed by an institution without unnecessary diverts or without errors popping up because your staff is stressed. So again, that type of question may be missing the point about demand and supply.
So sometimes I talk to my colleagues in different healthcare and say, you know what, we already provide good care. We don't need any of these.
We all provide good care. And who is the we? I think is a great question. Who is we? Is it all the nurses? Is it all the physicians? Is it all the ancillary staff? What are your patients saying? We think we provide good care. Do they think so? Would they recommend your hospital? What is good? Is good outcomes? Is good a profitable bottom line? What data are you using to decide that you have good care? We all want to have good care. I want to give the best care to my patients. How do I know I'm giving it? How does anyone who's in a large institution or even a small institution know they're doing well? Saying you provide good care is an assertion. Data has to be brought forth and has to be honestly collected data. And organizations need to have the courage to truly understand their current state and all the problems that are in that current state.
So we learned from the last talk and about the lean, and we hear about the lean that it's all about efficiency and going faster. When we compare that to the healthcare, some may argue that patient care cannot be rushed.
Patient care can't be rushed. That's true. That is true. Most hospitals understand the concept of quality, cost, delivery, and safety. And lean is really about maintaining the balance between these things. So what is faster? What is more efficient? Well, more efficient could mean your patient waits a shorter amount of time for their surgery. More efficient could mean, hey, I don't have to use 5 different forms to order my CT scan, or we've staffed the CT scanner in such a way that we never have downtime. So if the patient's not waiting for their care, that's higher quality care. If physicians aren't buried in overly complex electronic health records or overly complex systems to get simple tasks done, that means we can spend more time at the bedside with our families, which is why we went into healthcare in the beginning. So more efficiency is about creating time to do the things that we really want to do, spend more time with our patients, think more deeply about the next step so that they can go home and live a healthy life.
So what if their hospital is a union shop? How do we work with the labor union?
Labor unions should and must exist, and lean exists to make the job that people do on the front line easier. Lean exists and Kaizen exists, TPS exists to bring the potential out of every single one of your employees. Unions exist to protect the employees. Unions exist to be sure that we're not taking advantage of employees and that the workloads that we give them are fair. TPS does exactly that. TPS is a system designed where the frontline staff solve the problems in front of them, and in so being, their jobs become more efficient, more enjoyable, and they feel the satisfaction of improving the methods which they employ every day to do their jobs. It's about pride in work, and TPS is designed to do that. It does not work against labor unions in any way that I see.
So the performance improvement and quality department may ask this question: how can we possibly fix everything?
Oh, you're not gonna fix everything. It is PDCA means that you're lowering the water level with every interval improvement, that it uncovers more errors and more problems. Some hospitals have internal consulting agencies, and these internal consultants are okay, but at the end of the day, you want to make sure your consultants are no longer needed. You want that knowledge that a good consultant has should be passed back to the people on the front line that are actually doing the work. You do this because it's not possible to fix everything. You do this because even when you think you've solved a problem, you must continue to iterate on that improvement and make it even better. That's actually the cycle of Kaizen. That's actually the cycle of PDCA, is to always say that it's not good enough. And if I was a patient, I would want every member of the hospital that I was admitted to, I would want every member of that hospital to have the same mindset that it's not good enough. It must be better. It can be better. And TPS gives people a method to do that.
So some of the senior leaders at the hospital or institution may say, you know what, Kaizen work is for the front line, not for me.
Well, nothing could be further from the truth. What did FDR, Franklin Delano Roosevelt, do when his nation was in trouble? What did Winston Churchill do? What did Martin Luther King know? What did Mother Teresa know? What they know is that leaders have to go first. Leaders should be innovating. They shouldn't be hiring other people to do the thinking for them. Leaders should spend 80 to 90% of their time trying and doing new things. In many Western corporations, leaders spend most of their time thinking and less of their time doing. And it should be the opposite. It actually should be the opposite. So Kaizen starts with the leaders. They are very attuned. Frontline staff is very attuned to what the leaders are doing. Leaders must go first. Kaizen is for everybody.
So how does focusing on defects and problems help us? It seems very negative to me.
Problems are negative. Yes, that's the thing. Will the fear that you're pointing out that the way you do things now is not the best way, will that stop you as a leader from improvement? Of course it will. It'll stop improvement absolutely dead in its tracks. Hiding problems is the worst thing you can do. I'll repeat that. Hiding problems is the worst thing you can do. And Taiichi Ohno would say this. He'd come to the shop floor and he would look for evidence that people weren't making problems visible, because those hidden problems will cause errors and cause longer lead times. And then in our industry, in the healthcare industry, those hiding those problems results in patient harm. So, we can make two choices as institutions, as hospitals, as caregivers. We can choose to be an ice cream salesman. What I mean by that is everyone's doing a great job, and we're going to pass out ice cream sandwiches to everybody despite the performance. Or we can be more like TPS and make the uncovering of problems the norm. There's no shame in uncovering a problem. The shame comes from hiding the problem, and the harm comes from hiding the problem. So we're not ice cream salesmen. We're healthcare providers, and our patients deserve, demand, and should receive the highest healthcare possible, the highest quality healthcare possible.
So Kai means change, and Zen, good, basically to make things better. These are Japanese terms. We're American. Can we use different terms?
Oh, call it whatever you want. Call it whatever you want. Rebrand your current improvement nomenclatures. It doesn't matter what you call it. It really doesn't. If culturally that's a turnoff for your workers, then don't use those terms. What you'll find is if you're serious about change and you have an open mind, like we spoke about last time, that once your workers achieve even the smallest degree of success, they're going to become essentially addicted to change. Improvement begets improvement. But you can't improve unless you make the problems visible. So, here at Seattle Children's, we've gone through a number of different brand nomenclature changes, but the spirit is the same. The people understand PDCA. The people understand and can see and can feel that they're providing higher quality healthcare for our patients and families. So call it whatever you like.
My final question is, when do we stop doing Kaizen?
When you stop doing Kaizen. Kaizen is really about survival. It's about economic survival. It's about patient outcomes and survival on a very human level. When there's a term that my sensei, and I need to mention, his name is Jun Nakamura, and he received training from those who actually trained directly with Taiichi Ono himself. And virtually everything I've said in the last two podcasts, I've learned from him. And he would say that when there is no need to survive any longer, that is the time you can stop doing Kaizen. And as you think about suffering that our patients endure on a daily basis, that really is the attitude that you want in hospitals, or really around the globe.
Dr. Migita, thank you again for your time and accepting our invite to be on the line and talking to us about the Kaizen. We will have another 2 series on Kaizen number 2 and Kaizen number 3, where we have more questions on these topics. And for our audience, we encourage you to listen to our Kaizen number 2 and Kaizen number 3 podcast from Dr. Migita. Thank you very much.
Thank you so much.
Thank you for joining us. To subscribe to additional podcasts, visit sma.org/podcasts.